Good evening, everyone. Myself, Dr. Poonam Shah from Integra Pharma, would like to welcome you all for our today's session, Gynoscience, a medical education initiative presenting VVI Times. Before we move on for our today's session, I would like to give you a small brief about Integrace. So, our journey began in the year 2018, and since then, we have been ranked as the youngest among top 85 pharma companies in India. And we have been ranked as 13th in the gynecology represented market. Trusted by more than 42,000 Indian doctors, among which there are more than 5,000 gynecologists. We are leaders in two therapy areas, ANC care, wherein we have the progesterone and the hematinic, and the vulvovaginal infection management. To take our session forward, I would like to introduce and invite Dr. Ashwini Bhalerao Gandhi. Dr. Ashwini ma'am has done her MD, DGO, DFP, FCPS, DNB and FICOG. She is a consultant gynecologist at PD Hinduja Hospital and Hinduja Healthcare Surgical, Mumbai. She is a president at the Mumbai Menopause Society 2019 to 21. She has been the vice president for the Federation of Obs and Gynecological Societies of India 2013. She has been the president for the Mumbai Obs and Gynec Society from 2012 to 2013. She has been the chairperson of Adolescent Health Committee of FOXY from 2004 to 2008. She is an ex-associate professor for TN Medical College and Nair Hospital. She is the secretary for the Journal of Obs and Gynec Society of India. She is a consultant gynecologist at the Vulva Clinic, which is the first in India in Hinduja Hospital in Mumbai. So with this, I would like to welcome Dr. Ashwini ma'am, and over to you, ma'am. I will stop sharing here.
Thank you, Poonam, for your kind introduction. At the outset, let me thank Integrace for inviting us to conduct today's webinar, which is related to vulvovaginal health and diseases. This topic is coming up as a subspecialty, as many gynecologists and even dermatologists, etc., are dealing with various aspects of vulvovaginal health in a very different way. We are very fortunate to have three very good speakers who will be covering different aspects of vulvovaginal health and diseases today. It is my proud privilege to introduce the first speaker, Dr. Girish Mane, who is director at Mane Hospital, Yavatmal. He is chairperson of Adolescent Health Committee of FOXY for the years 2019 to 2021. He has been chairperson of Adolescent Health Committee of all Maharashtra OBGYN societies from 2018 to 20 and was awarded Best Chairman Award for AMOGS. He has also bagged FOXY's Smriti Milan Save Baby Girl Runner-Up Award. He is recipient of Dr. Dhurusha Youth Trophy and Dr. Sadhna Desai Award in 2017. He has been editor of FOXY Focus on Adolescent Intervention for Future Reproductive Health. He will be talking today on maintaining hygiene during menstruation with contemporary and newer protective devices. All of us are aware that women and girls all over the world, in cities and in rural area, they use various modalities to protect themselves or safeguard themselves from the menstrual blood leakage. And we always want to thrive for the best, what is best for the girls and the women, and also which is best for the environment. So let us hear from Dr. Girish Mane about this contemporary as well as newer protective devices. Dr. Girish Mane, please.
Thank you, madam. Good evening, ladies and gentlemen. At the outset, I would like to extend my sincere thanks to Integrace for this wonderful opportunity, and my sincere thanks to Dr. Ashwini madam, not only for this opportunity, but her time to time the cooperation and coordination and her blessings with me for always. So today I am going to talk on a very interesting topic, which is really, not only interesting, but it is necessary for everyone, because in most of the webinars, we are talking about some diseases. The diseases are faced by a very small population always, but the menstruation, which is a day-to-day and a regular practice, which is very important for all the girls, for all the women, and everyone has to face these problems, and that's why it is mandatory to talk on the menstruation and the maintaining the menstrual hygiene. And today we are going to cover some important topic, that is the contemporary and the newer protective devices. First of all, my naman to my God, Shivaji. Today is Shivaji Jayanti, so happy Shiv Jayanti to everyone. And this is something regarding me, and these are the key terms I think everyone is well aware of. Menstruation or menses is the natural body process of releasing the blood. Then menarche means onset of the menstruation. Menstrual hygiene management refers to the management of the hygiene associated with it. A menstruator is a person who is menstruating, either a girl or a lady or a transgender also. Then menstrual hygiene materials are the things which are used for that management, like in the form of pad, cloth, tampons, cups, or some other material. And menstrual facilities are the facilities which are needed, like toilet, water, infrastructure, so and so. Friends, access to safe, non-shameful, non-stressful, and dignified menstruation is a fundamental need and right of every woman and girl. And the scenario in India, especially the scenario in the adolescence of the India, is very horrible. Almost there is no discussion regarding the process of menstruation in 100%, and you can see on the screen most of the girls, they are not aware of the many facts regarding the menstruation, and almost 6% they had never heard about the sanitary napkins also. And friends, there are many criteria to choose the method of menstrual hygiene management, and they depends upon the culture and context, the health and financial, economical situation or condition of the person, then how it is used and what are the cares to be taken and how is the disposal. Then it depends upon what are the local menstrual beliefs and practices. It depends upon this condition. Then what are the local level of knowledge about this menstrual hygiene management, and what materials are currently used and available in this area, particular area. Then which materials are preferred by the neighbors or the nearers or the mother or the other people. Then which materials are preferred by the girls and women with a different type of disabilities, and whether it is wet or dry. So these are the conditions according to the culture. Then is the material associated with the health risk? Then what is the average age of menarche in that community or in that race or in that area? Then it also depends upon, is the method going to injurious to the hymen, or if the female genital mutilation or cutting is practiced locally. These practices are very found very in less areas, but also it matters. Then there are some financial or economical conditions also, whether what is the single use cost of that material, then what is the life cycle cost for that instrument or material. Then it depends upon, is that material or the supportive supply, they are affordable to that person or not. Then are the girls and women, they are familiar with that material? How frequently does the material need to be changed? For example, the menstrual cup, it's used for a longer time, and the pads, they are used for a short time. So this depends upon the frequency also. And does the material require supportive supply, and are they available? For example, if the reusable pads, they need frequent washing and the area for the drying, if they are not available, then that will not be a proper or suitable method for that particular girl or a woman. Then how is the material clean, and are the supply available? Then availability of the private spaces for washing, drying and changing. For example, in the metropolitan city where there are small spaces for living, then it's very difficult to get the spaces for washing, drying and changing and so on and so on. That's why these criteria, they are always used for choosing the method or the material for the sanitation. Then how the material is absorbing or drying or preserving. For example, the menstrual cup is very easy to preserve, but to preserve the reusable pads or the menstrual clothes, especially in the season of rainy or in the winter season, it's very difficult. So these all conditions, they are depends upon the use of that material. Then the method of disposal also matters. How frequently must the material be disposed of? Then what are the local beliefs about the different methods of disposal? Then are discrete disposable points are available for the used materials? All these things, that depends, isn't it? So in India, the menstrual hygiene materials used frequently or commonly, they are the menstrual clothes, the reusable pads, the commercial sanitary pads, the tampons, the reusable tampons, the menstrual cup, bamboo fiber pads and banana fiber pads. So let's see quickly what exactly these things are. The menstrual clothes, they may be sustainable sanitary option, but they must be hygienically washed and dried and sterilized in the sunlight. So they depends upon the sunlight, and that's why in the rainy season or in the winter season, the woman or the girls which they are using the menstrual clothes, they get the problem. There are some advantages. For example, they are cost effective, they are easily available, and they are eco-friendly because they are biodegradable. But there are some disadvantages in the form of vaginal discharge or skin irritation or urogenital infection. Then coming to the reusable pad, they are of natural or synthetic material, and after use they can be washed, they can be dried, and they can be reused, and approximately they can be used for 1 year. There are many advantages for these reusable pads. There is a little bit, there are very little evidences of health impacts of their use. They can be used for approximately 1 year, and that's why they produce very small solid waste, and that's why they are nature friendly. The initial investment may be little bit high, but the annual cost, if you calculate in in comparison with the regular sanitary pad, then it is little bit less than the regular sanitary pad. There are some disadvantages of these pads. For example, they can cause a urinary tract infection or bacterial vaginosis, and sometimes if these material they are damp, then they can cause skin irritation. And in the rural areas, the availability can be problem for these reusable pads. Now coming to the commercial sanitary pads, they are very easily available anywhere. I mean, in the stores, in the chemical shop, even online. The cotton used in their making is not 100% natural, and they may contain the chemicals in the form of the gel or pesticides. These pads, they are in various sizes, and different kind of absorbents that they are used, and different kind of materials are used. And even they can I mean, there is a use of the plastics, the rayon and cotton in this sanitary pads. There are few advantages for the use of these pads. They don't have any significant adverse effect because most of the pads, they are sterilized and they are used for only one time, and they are disposed of later on, and that's why these are little bit I mean, they are having this positive use. Then the skin compatibility is very high, and these disposal pads, they are very well tolerated by most of the users. But friends, they are having lot of disadvantages, just like this picture. They need to be disposed of after the maximum use of 8 hours. Then they are very expensive if compared to the cloth pad for the complete cycle. Minimum 12 to 24 pads they are used in a complete cycle in compared to the cloth pad or the reusable pad. Then they are non-reusable, they are not eco-friendly, and most of the pads, they are non-biodegradable and they contain chemicals. Friends, one woman creates 150 kg of non-biodegradable waste in a year. Then 1 crore pads, they are used in a single month in our country, and one pad take almost 100 years for the complete decomposition or for the degradation. Then India produces almost 1,13,000 tons of menstrual waste in a year in the form of these sanitary pads. Then as pads are disposed after one use, they create large quantities of the litter, then accumulates in the landfills, they blocks the sanitation systems, and they even they contaminates the rivers if they are thrown in the river, in the places where the rivers are side by those places. Then disposal of the used pad in the flush toilets can lead to the clogged pipes and sewage backflow in the buildings, and presenting a serious health risk and the maintenance problem to the people. They releases the toxins if they are burned incorrectly, and these toxins, they are injurious to the health, and sometimes they are cancerous also. Now coming to the tampons, tampons are absorbent material made up of cotton and or the rayon, and it is supposed to be inserted into the vagina to absorb the menstrual flow. They expand with the moisture, and thereby they avoid the leakage, after which they are removed using the removal string which is attached to the tampon, and they are disposed of. They come in a variety of the sizes and variety of the materials, with or without an applicator which assists for the insertion. They can be worn up to 6 to 8 hours according to the flow of that lady. And nowadays there are some other kind of sponge. They are known as sea sponge tampons, which are available in the market, and they are natural. And that's why they are eco-friendly. So the only advantage in the tampon is they are the sea sponge tampons, they are biodegradable, and they are little bit comfortable for the person in comparison to the sanitary pads, as they are worn inside. Again, it has a lot of disadvantages like sanitary pad. They are not user friendly. the virgins or the unmarried girls, they may not be comfortable with this. Most of the ladies, they are not comfortable with the use of tampon. Then they are expensive, and they may be associated with the toxic shock syndrome if not properly hygienic. I mean, if somebody is using this tampon without proper care of the hygiene, even the person can land up in the toxic shock syndrome, and you know what are the what consequences can be there because of the toxic shock syndrome. But the UTI and the vaginal infections, they are common with this use of this tampon. Then residual chemical and fragrance can lead to the allergic reactions with the tampon. As tampons are disposed after one time wear, they create large garbage, and they are not easily degradable in the nature, and hence again they are not environment friendly. The flushing of the tampons in the toilet is very common because they are small in size, and the woman, they thinks that it is very easy to flush all this used tampon in the toilet, and this can lead to the clogging of the pipe, again the service disruption and increased maintenance cost, sanitation cost. When burned incorrectly, again they releases some gases, the furans, which are highly volatile chemical compounds, and they are toxic. They can cause many harm hazards to the people, and even they are having some precancerous effects also. And that's why these tampons, they are same like sanitary pads. Then coming to the reusable tampons, these are washable tampons and made up of the natural material like bamboo, wool, cotton, or hemp. They are knitted using the natural absorbent material like cotton or wool, and they are inserted into the vagina to absorb the menstrual fluid, same as the disposable tampon. The only advantage are they are biodegradable, they are nature friendly, they are reusable, and that's why they create a small amount of the garbage for the disposal. And the disadvantages are they are not user friendly, again they are expensive, and the most important thing, they are not easily available, and again they can cause toxic shock syndrome if the proper care of the hygiene is not taken. Now coming to the very important topic of today is menstrual cup. Friends, the menstrual cup is a non-absorbent bell-shaped device that is inserted into the vagina to collect the menstrual flow. It just a moment, I have so yeah. It creates a seal and is held in place by the walls of the vagina. It is typically made up of the medical grade silicone. It collects 3 times more blood than the pads and tampons, and need to be inserted after or need to be emptied after every 6 to 12 hours, which depends upon the amount of flow that female is getting, and after which it is rinsed and can be reinserted again, and it can be washed just by a simple clean water also. After each menstrual cycle, the cup must be boiled for 5 to 10 minutes for the disinfection, and most manufacturers, they offer the menstrual cup in 2 sizes, small and large, and they are coming in different shapes also. And these cups, they can be used for 5 to 10 years depending upon the use, depending upon the boiling, depending upon the maintenance of those cups, and the cost ranges from 350 to almost 2,500 according to the company and the material of that silicone. These cups, they are having very small disadvantages. The first disadvantage is culturally there are some barriers, and many women, they are not comfortable for the use of menstrual cup, and it is less acceptable and advisable in unmarried and especially in the virgin girls. But it is having a lot of advantages. They are easily available. Number one, they are reusable. It is the cheapest method of manage this menstrual hygiene method. Maybe they are initially the first costing maybe a little bit higher, but if you are calculating the cost of menstrual management for a year or for 5 to 10 years, then probably this is the cheapest method for menstrual hygiene management. It works for longer time, and that's why very less frequency of changing, because one can change the menstrual cup after 6 to 12 hours. And we are changing the pads, or we are most of the time the tampons or the pads, they need to be changed after 6 to 8 hours. The cup can be used for 5 to 10 years, and thus they produces significantly very less waste than the other menstrual hygiene management materials. They are eco-friendly. There is no environmental injury. This is very important. Then there are no expenses needed for the disposal, which are needed for the disposal of the tampons or the pads, even for the reusable pads. Then there is no harm from the toxins or the fumes, because there is nothing like that here. Then very less health issues to the users. Then no damage then no damage to the sanitation or the drainage system in the buildings, then no health issues of the sanitation worker, then no feeling of shame for the disposal which is there in the disposal of the pad or the tampons. Then cups are often perceived as better than pads or clothes in relation to the ease of washing, drying and storing. It is always easy to wash the menstrual cup rather than the reusable pads or the menstrual cloth, because it is made up of the silicone which releases the blood very easily, and they are comfortable for use. They are having great leakage protection. There is no odor development with the menstrual cup, and the quality and length of wear is probably better than the use of the tampons or reusable pads or sanitary napkins. So there are a lot of advantages with the menstrual cup. Now coming to the bamboo fiber pads, instead of wood pulp, bamboo pulp is used as an absorbing material in the sanitary pads, and it has more absorbing capacity and is safer to use. There are some advantages. For example, it is affordable, they are easily decomposed, and that's why they are environment friendly. This provides the infection and irritation free menstruation because it is made up from the natural resource. Also, the bamboo charcoal pads that are available in the market with advantage that the blood stains are not clearly visible and are also reusable in the nature. The only disadvantage that there are some issues with the hygiene and they are not easily available everywhere. Probably they are available in the areas where they are prepared. Now coming to the banana fiber pads. Nowadays, the low-cost sanitary pads for the rural woman made from the waste banana tree fibers, they are sold under the trade name of Greenie. For example, this is here, and Sathi in India. They are environmental friendly and decomposes within 6 months after the use. Besides this product, women in the remote areas, they are also using some natural material like cow dung, leaves and mud, but they are not hygienic. So the advantage is that it is biodegradable, so it is eco-friendly, and the disadvantage, it is not available everywhere and hygiene can be the issue. The water hyacinth pad, this is water hyacinth, and these pads, they are made up from this material, and the menstrual pads manufactured using this water hyacinth is sold under the trade name of Jani in India. They are eco-friendly because they are made from the natural resources. Now coming to the summary of this material. So this table will show you the comparison of all the management these materials which are used for the menstrual hygiene methods. So the reusable I have created this table and I have compared the menstrual cloth, the reusable pad, sanitary pad, menstrual cup and tampons with all the comparative issues. So this table, they predict that the menstrual cups are the best, probably the best instrument for the menstrual hygiene management if you are comparing everything. I mean the cost, the availability, the cleanliness, less health issues, the cost and everything. Friends, there are so many issues in the menstrual waste disposal, isn't it? So the menstrual waste disposal technique used by the woman, they are appropriate disposal of the used menstrual material is still a problem in most of the countries, and especially in India, in the rural areas of our country. Most of the countries, they have developed the techniques of management of the fecal and the urinary waste, but there is no disposal method for the menstrual waste. Most of the women dispose of their sanitary pad and other menstrual articles into the domestic solid waste or garbage bins that ultimately becomes the part of solid waste. The toilet facilities in India, there are lack of bins for the disposal of the sanitary pads and hand washing facilities for the menstruating woman to handle the menstrual hygiene. In urban areas, most modern disposable menstrual products, they are used and they are disposed of them by flushing in the toilets or throwing in the dustbin or through solid waste management. But in the rural areas, there are many options for disposing the menstrual waste, such as by burying or by burning or by throwing in the garbage or in the pit latrines, because there are so many, I mean, ample of space is there in the rural areas. In rural areas, mostly the women, they are using the reusable and non-commercial sanitary material like reusable pads or clothes, and that's why they generate little bit lesser amount of the menstrual waste as compared to the women in the urban areas. The menstrual material is disposed of according to the type of product used, the cultural belief and the location of the disposal. In school, due to the lack of sanitary facilities, the girls throw their pads in the toilet. In some cases, the girl throw away these used material clothes without washing also, and that's why there can be spread of many diseases because of this disposal of these used menstrual clothes also. Also, the many were reported being absent from the school due to the lack of disposal system, broken lock, the doors of the toilet, lack of water taps, bucket, and poor water supply. If the girl is studying in the school and if she is menstruating and if there are no facilities for changing of her pad or for the proper disposal of this pad, then definitely she is supposed to be absent from the school. In some schools, the incinerator or feminine hygiene bins, they are used for disposing the menstrual waste material, but due to the shyness or fear for being seen by some others, they refrain from using it. The behavior of the woman regarding the disposal different in the home, and it is definitely different when she is away from the home. At home, they dispose the waste by wrapping properly and by throwing it into the dustbin along with the domestic waste. But when she is in public, most of the ladies are flushing these used tampons or the pads in the toilet, and that's why they are creating a lot of problems with these toilets and all the sanitary mechanisms. Then many times they are keeping these used pads in the corners of the toilet also. This makes the toilet dirty and breeding places for the flies and mosquitoes, and also unhygienic for the other people who are using the toilets and the cleaners especially. The person who manages the public toilets always complain of blockage of the sewage system because of the flushing of the sanitary pads and rugs into the toilet. So there are a lot of consequences of the menstrual waste disposal. Mostly the sanitation system are unable to cope up with the menstrual materials, which clogs the sewer pipeline and cause the system backflow. And this material like tampon, the cotton wool, the toilet paper, and other organic material used for menstrual management might be decomposed in the pit latrines, landfills, except the plastic inlay of the commercial sanitary pads. The sanitary napkins decomposes over a period of about 100 years. It's a very long period, you know. In rural areas, the pit latrines, once full, they can be covered with the soil and the new pit can be dug. But due to the limited space in the urban areas, it is not possible practically. It was reported that some women and girl wrap their used menstrual clothes and pack in the polythene bags before disposing in the pit latrines, which prevents them from the proper decomposition. And that's why instead of using the polythene bag, it should be properly wrapped in the paper, newspaper, and then it should be thrown away in the bins or the pits. Nowadays, mostly the women or the girls, they are preferring the commercial sanitary pads and tampons, which are made up of the super absorptive material like polyacrylate. These pads and the tampons, when flushed into the toilet, they get saturated with the liquid and they swells up, and thus resulting in the sewage, this backflow and serious health hazards to everyone, the people who are using that toilet, and even the person who are using or who are cleaning those toilets. And that's why proper care should be taken regarding this menstrual waste disposal. Then deodorized sanitary products used by the woman or the girl contains chemical which is used in the bleaching, such as organochlorides, which when buried in the soil, it disturbs the soil microflora and the decomposition takes little bit more time, isn't it? Then people living alongside the river banks throw their menstrual waste into the water, which contaminates that river and that water. And this material soaked with the blood were breeding places for the germs and the pathogenic microbes. The sanitary products soaked with the blood of an infected woman or girl by the hepatitis or by the HIV, they spreads the disease. And these bacteria or these viruses, they live up to 6 months in the soil. This is very dangerous. Then the clogged drainage with the napkin has to be unblocked and cleaned manually by the sanitation worker, which can get the health issues while cleaning all this stuff. Then incineration is a better technique to dispose of the menstrual waste, but burning of the pads releases the harmful gases that affects the health and environment. The burning of this inorganic material at low temperature releases the dioxin, which are toxic and they are carcinogenic in the nature. So these are the strategies which, if we are following, then we can take proper care of the management of the menstrual waste. Number one, the disposal of the menstrual waste is of the major concern as it affects the health of environment. There is a need for effective menstrual material which needs less and cost-effective management for the disposal. Then companies dealing with the manufacturing of the sanitary pads or other articles should disclose the information on the pad regarding the chemical composition of that pad, so that the appropriate technologies could be used for the disposal and the treatment. Then environment friendly chemicals should be used by the manufacturers of the sanitary pads to stop the soil and water pollution and to hasten the decomposition process. Actually, in most of the cases, the chemicals used in that sanitary pads and the chemicals written on the pads, they are different. Actually, they are not writing the name of the original chemicals they are using, and that's why the disposal methods they are failing in most of the cases. Then guidance regarding the menstrual management to the adolescent girls and women is a much needed step at this time, and menstrual hygiene management should be an integral part of the educational curriculum in most of the academics. The distribution of the menstrual products should be free of cost in schools and education institute. But friends, recently, instead of subsidizing the menstrual pads, Indian government has imposed 12% GST on them, which is definitely not woman friendly. The toilets must be designed and built to be girl and woman friendly. Then there should be a separate collection system for the menstrual waste without affecting the privacy and dignity of a woman. Specific sanitary dispenser to collect the menstrual waste should be installed in the school and public places, especially in the toilet areas. Then there should be sufficient space for washing, cleaning private parts and hands, and for changing or dealing with the stained clothes. To fulfill these requirements, there must be availability of clean water, then availability of toilet papers, availability of the dustbin and sink to wash the menstrual products. The dustbin should be covered by the lid and emptied for time to time to keep the toilets clean from the flies, mosquitoes, and bad odor. And they should the covered containers and dustbin have advantages for hiding the waste being seen by the others. They should be installed in a places that offers the privacy, and the girls or the women, they shouldn't feel shy for the proper disposal of their used material in those bins. Then the gloves and proper safety tools should be provided to the people who are cleaning these things, and they should not be exposed to the pathogenic organisms and harmful gases. And government should introduce new rules for the safe disposal and treatment of the menstrual waste, as they have made for the solid and biochemical waste. As all doctors, they know there are norms and there are some rules for the this disposal of the biomedical waste which is arising from the hospital, but the rules, they are not for the disposal of the menstrual waste, and that's why there is a need of appropriate policy and legal framework should be made for the management of the menstrual waste. The government and non-government organizations should come forward for making the people aware of the management of the menstrual waste, and government should give the funds to the municipal corporation as well as the NGOs for the construction of the woman-friendly toilets with the facilities of proper water, soap, and privacy, and so and so. The health impact of the menstrual waste should be properly investigated, and financial support should be given to the institution to carry out the research in the management of the menstrual waste. Scientific research should be encouraged for the most suitable techniques of disposal of the sanitary pads and other menstrual products. And allocation of budget in the school to support the menstrual hygiene management studies should be conducted. Then collaborative efforts, that is trash bin, should be made, and incinerators are the bestest of this option for the disposal, but should be operated in a controlled environment so that the harmful gases emitted will not harm the larger area. So coming to the last part of my talk, what are the better ways and ideas for disposal menstrual waste? So they are the incinerator, the reusable pads, the biodegradable products, then the clay or the cemented incinerators, and better disposal techniques. So friends, these are the clay or this cemented incinerator, then these are the reusable pad, and these are the incinerators. So to conclude my talk, these are the take home messages for all the doctors, that every medical person should be aware of these facts. I mean the facts regarding the what amount of pads we are creating, what amount of menstrual waste we are creating. Then one pad takes around 100 years for the proper decomposition, and there is a creation of 1,13,000 tons of menstrual waste in year, and there is a use of 1 crore pads only in a 1 month in India. So these all facts, they should be known to every medical person, number one. Then we should educate the society about these all things or these facts. This is very important. So all the doctors, they can take some efforts to educate their patients or the relatives or the nearest or dear ones who are non-medicals regarding this all knowledge. Then start using and encourage to use the reusable pads, or especially the menstrual cups. And I am 100% sure that most of the doctors, even though they are in favor to use the menstrual cups, they are not using the menstrual cups themselves. So it's very difficult to advise your patient also. So please start using and even encourage your patients to use the reusable pads as well as the menstrual cups. Then avoid using the non-biodegradable material in the form of the tampons or the sanitary napkins for your own menstrual hygiene management, and use the incinerator for the disposal of the non-biodegradable this material. These are not the take-home messages, but this is a request from me, from Ashwini madam, and from everyone. So please take these messages to your patient, and thank you very much for this patient's hearing. Thank you very much. Hello, over to you, madam.
Dr. Girish. You have elaborated on different modalities which can be used by the girls and women to take care of the hygiene during periods. There are a few questions. Dr. Nantini Sarvanan from Karaikal, she is asking, what are the challenges in optimizing menstrual hygiene in mentally challenged girls?
Yeah, this is very good question. Basically, it depends upon the severity of the mental illness of that girl. Many girls, if they are properly educated and they are properly trained to take their own care, they obeys and they follows the proper menstrual care. But sometimes there are really practical issues with the mothers, and it depends upon again the age of that girl, the severity of mental illness, and the other people who are helping the mothers. And that's why it is really a very horrible issue. But I have gone through some cases where the girls, they have been hysterectomized because of the complaints like heavy menstrual bleeding and difficulty of getting the proper menstrual care. So the scene depends upon the severity, the age, and the the other things also.
I think, Girish, out of whatever different ways you have described, menstrual panties may be little easier for them.
Yes, madam. Menstrual panties
not to be tied, or it is just like a regular panty what she otherwise is wearing, and it soaks all the blood. And they maybe after 12 hours or something, it can be just removed and another panty can be worn by the caregiver. So maybe that can be used. And in extreme cases, after taking psychiatrist advice and the mental age and even medico-legal factors considering, the last resort should be, I think, asking for a hysterectomy.
Exactly.
So we have to try different options as far as possible. So one more question from Dr. P.A. Ramani from Visakhapatnam. How to provide cheap and best solution without harming environment? I think environment you have really
the banana
elaborated on many aspects, but cheap. I think they are also asking for a cheap option.
Basically, the reusable pad, that is the cheapest and best option in my opinion, because they can be used for 1 year, and comparatively the number of pads used in a cycle, they are lesser than what you are using for the sanitary the commercial sanitary napkins. Then even I have already elaborated the cost. The menstrual cloths which you are using, if the lady is using the newer cloths, then the maximum cost for 1 year is going to be 400 to 500 only. If they are using the reusable pad, the maximum cost for 1 year is 800 maximum. But the cost for the sanitary napkin, sanitary pads which we are using, or the tampons, it goes around 4,000 rupees in a year. And if you are considering everything, then the menstrual cup, they are the cheapest one, because they are supposed to buy for one time only, and they are used for more than 5 to 10 years. And they are costing from 350 to at the max 1,500 or 2,500 depending upon the quality of that silicone and depending upon the this company. So if the lady is comfortable to use the menstrual cup, then in my opinion the menstrual cup is the cheapest and the best and the most cleanest way for taking care of this menstrual hygiene.
Very true, Girish. And I think as gynecologists, it is our duty to tell different options to the patients. They may not be aware. And maybe at least we can give some pamphlets, we can give them some links, so that they can go on those links and find out about the different ways to cut down the cost and also be environmental friendly. There is one more question by Dr. Saumini, but I think that we will cover later on because it is related to atrophic vaginity. So maybe Dr. Priya Vora later on can cover. Shriman, if there are no other questions, can we go to the next talk? Thank you, Girish. It was a really very good presentation, eye-opener.
Thank you, madam.
Especially as far as the environmental factors are concerned. And now let us go to the second talk of today. It is my privilege again to introduce my friend Dr. Sudha Tandon, who is director at Tandon Fertility, IVF and Maternity Hospital at Chembur and Navi Mumbai. She has been working as gynec endoscopic surgeon and IVF consultant for more than 25 years. She has been chairperson of FOGSI Committee on Sexual Medicine from 2017 to 2019. She has been working as the managing council member of Mumbai Obstetric and Gynec Society since last 9 years. Also, she is a member of managing committee of IAGE for last 6 years. And she has been the president of Surgical Association of Chembur from 2017 to 2019. She is recipient of Best Paper Presentation Award at 46 AICOG held at Orissa on fertility enhancing hysteroscopic procedures. And Sudha, you are going to talk today on sexual dysfunction in women because as menstrual periods and hygiene is at one side, the next problem when the girl or the woman enters sexual life is about sexual dysfunction. So what are the different problems she faces and what are the solutions we can offer to her? Dr. Sudha, we are waiting for your presentation.
Thank you very much, Ashwini, for the kind words. And it's a real privilege and honor to be here and speaking on this topic of these female sexual problems, which we are probably not very much aware about. And we ourselves shy from, taking care of them. So can I just share my screen? Yeah. This is it, no Microsoft PowerPoint. So is my screen seen?
Yes, we can see it properly.
All right. So sexual health, as we all know, is really very vital quality, and female sexual disorders or problems, they seem difficult to treat. But we physicians should not dismiss or ignore these problems because, the women do not ask for it, but it is our responsibility to initiate discussions about these matters and know what to say and how to manage them. And this is not, it's an international problem. And it was seen that 44% in US, reported to have sexual problem, especially desire, arousal, and orgasm, and 38% reported hypoactive sexual disorders. So I have little basics about what the sexual issues are, and then we'll go to the individual sexual problems. I cannot go forward. Oh.
Madam.
Yes.
Just double click on the screen.
Screen?
I mean the main screen. Just have a double click on the main screen and then start. Yeah.
So now it's come. Okay, fine.
Yes.
Yeah. Female sexual problems is actually a continuum of psychosexual disorders, and it is centered on the sexual desire with interrelated problems of arousal. And it must be stressed that it affects the age group, all age group women, and the impact may be subtle. It may be unrelated emotional disturbance, minor short-term problems, or could have debilitating consequences. So sometimes it's very quick diagnosis. Sometimes it may take time to come to the conclusion as to what it is. Most often we'll be able to tackle it, but sometimes we need to take help from an expert. So this was the classification of the female sexual dysfunction, which is DSM-4, and it was classified into the sexual desire disorders, which was a hypoactive sexual desire disorder, then the arousal disorder, and the orgasmic disorder, the pain disorder. These were the main broad classifications. The pain disorders was dyspareunia and vaginismus. But this was revised, and the newer classification, which is again the 4 types: sexual interest or arousal disorder, the orgasmic disorder, the genitopelvic pain and penetration disorder, persistent arousal disorder. This I'm just going to touch in short, and I'll come to each disorder in a few minutes from now. And one must remember that all these disorders are not standalone, and they flow into one another, and probably they are also because of one, the other may be present. And if we take care of one, the primary complaint, then probably the other one also will get, like a pain disorder will give rise to a hypoactive sexual disorder. So they are all interrelated. So take care of one and the other one also will get corrected. So what is hypoactive sexual disorder? This is persistent or recurrent, deficient or absent sexual fantasies, thoughts or desire for or receptivity to sexual activity. But we must consider the age, physical condition, and the context of a person's life when we tackle this problem. And we should not be judgmental about it. The aversion disorders, it is recurrent, aversive response to any genital contact with a sexual partner and emphasize the role of avoidance. I'm not going to the detail because otherwise the whole time will get over in that. The arousal disorder is inability to complete sexual activity with adequate lubrication. The orgasmic disorder is defined as recurrent delay in or absence of orgasm after a normal excitement phase. And probably it is difficult to determine the incidence of orgasmic difficulties. Despite its importance in our lives, must realize that it's a very transient peak sensation of intense pleasure and might best be viewed as a reflex. Dyspareunia, the 2 common types are the dyspareunia and the vaginismus. We'll again go into the detail, whereas dyspareunia is defined as persistent recurrent urogenital pain occurring before, during, or after sexual intercourse that is not caused exclusively by lack of lubrication or by vaginismus. So one has to differentiate whether it is dyspareunia or vaginismus because the treatment of both is markedly different. We'll go into this in detail. Vaginismus is, and this is a very common problem which the patient comes to us, especially in the initial period after they get married, is about vaginismus. And sometimes it is very easy to correct. Sometimes it may take a lot of effort to correct it. So it is defined as involuntary, mind you, it is involuntary, recurrent and persistent spasm of the outer third of the vaginal musculature that interferes with vaginal penetration. So this was broadly about the classification. Then we come to individual problems and which is more relevant. Now, important from our point of view is fertility and the female sexual issues. Now, each month they'll keep trying and there'll be so much of concern, anxiety, guilt, blame, anger for not becoming pregnant. And sometimes they will go through so many treatment cycles, so much of time and resources will be wasted. But what was required is probably just a simple, finding out what the sexual history is and correcting it. And it was found that 40% of the women have sexual problem and associated with infertility, whereas in men it could be 30%. So it could be present either in the woman or the man or in both of them. So to know whether there is a coital factor in infertility and how to correct it, some important tips that I would like to give. So ask for their sexual history. Are they having sex? Most important. They may not be having sex. Frequency of coitus. Sometimes they may be just having once in 15 days or over the weekend. Is full penetration possible? Does he ejaculate inside? Does she douche or pass urine after having coitus? Any issue with sex? Simple leading questions. She'll be happy. You'll be happy that you have given her the correct diagnosis and treatment. Is there any motivation for having sex, or the motivation is only pregnancy? Have they given importance to sex in their relationship? So we have all such patients coming to us, and what is most important in the patients of primary infertility is to ask them about the sexual history. And why we ask them, by and large, do you have sex during the peri-ovulatory period? Now, it is right that one should have sex during the peri-ovulatory period to get pregnant. And one should know that the life expectancy of the egg is just 1 to 2 days, but the sperm, which is not washed, can survive in the genital tract for 5 days. But this itself creates a lot of anxiety in the man, and it can give rise to temporary erectile dysfunction, temporary anejaculation, loss of erection, loss of libido, lack of arousal, lack of lubrication, and coital issues, because you're timing the sex for the sake of getting pregnant. Whereas what is important is that you tell them you can have sex anytime. Most important, they can begin when you start your ovulation studies at the time of sonography by day 7, 8. Ask them to have every alternate day, because by and large, by the time they are in the fertile period, that having intercourse doesn't become mechanical, and they're really enjoying it, and they will not have any problem. If they have any issues, if the male has any issues, then probably sildenafil can be prescribed around ovulation. So this is a problem: planned sex, extensive painful tests, intense feeling of anxiety, personal issues like sex being externally controlled by a physician. So they do not like this. So probably if you just do not have so much of emphasis on that you must have sex only in that period, they will probably be very happy. They have poor communication, anger, avoidance of commitment, confused priorities. All of them will present as sexual complaints, regardless of the presence or absence of infertility. And if you go deeper down, the problem is that probably they are unable to have intercourse, and they come out with all these issues. So how do we take care of these? As I told you, that there are important questions that need to be asked, and any score which is less than 26.5, the desire, I'm not going to the detail, the desire, arousal, lubrication, orgasm, satisfaction, pain, everything should be looked into. And this is how is the scoring done. Any score less than 26 is classified as a female sexual disorder. Now, what are the tips? Let them discuss the sexual problems, educate oneself about the normal functioning, don't sacrifice rewarding sexual encounters, renew commitment, devote time to other activities, try sexual play, be creative, inventive. They should be, most of the time, if they're with the television or with the phone or with the laptop, they're probably not interested in having sex. Give them their time, try erotic books, board games, videos. So try to engage the couple in other activities, then sex doesn't become mechanical. But sometimes the sexual problems may even mask more severe psychological or marital problems, and should medical treatment for infertility proceed unchecked even when patients refuse psychological or sexual treatment? This is an ethical dilemma which we must find out, because just getting pregnant will not solve the psychological problems. So it's important that to see whether these are any major issues or they're just issues which can be handled or taken care. So now this patient is of vaginismus. So what have they come with? And what is the history? They are unable to have intercourse. She is averse to sex. And even on gynec examination, she'll be unwilling, keeping thighs absolutely adducted. And depending on the severity, they may even not allow the tip of the finger to touch. Okay, so what history, what is the diagnosis, and what will you do? Okay, so this is, it is involuntary and uncontrolled functions. Most common reason for unconsummated marriages. Friends, I have seen patients coming even 8 years, 15 years after marriage, they have not consummated their marriage. And then the pressure of getting pregnant is so much that just do an IUI, do an IVF, and the couple gets pregnant. In clinical settings, the incidence could be as high as 5 to 17%. They tend to be secretive about their problem and do not discuss this with anyone. They may go from one therapist to other, and there could be psychological, medical, or surgical treatments add to this failure. Sometimes there could be even a divorce. So what are the causes? You must go into the history and find about what is the views the woman has about sexuality, particularly whether there is any premarital sexual activity. There could be very strict religious or sexual upbringing, that sex is wrong, penetration can cause pain, injury, and bleeding. History of sexual molestation at a young age is a very one should be looked into. There could be fear of pregnancy, childbirth, or AIDS. Of course, you have to consider whether there is any other issues like sexually transmitted disease, endometriosis, hymen issues, etc. So depending on the grade, it's classified from grade 1 to grade 4. The severe one, the grade 4 is elevation and adduction, and they will just not allow even the tip of the finger to go inside. Sometimes there can be visceral reaction. Now, mild cases may respond to your Kegel exercises, encouraging relaxation of the pelvic floor, psychotherapy, counseling, cognitive behavioral therapy, hypnotherapy, support groups, physical therapy to stretch the vaginal muscles, biofeedback to reduce pelvic floor tension, lubricants could be used, anti-anxiety methods also, or drugs could be used. So, manual dilatation. These are the more common forms that one can do for treatment. Manual dilatation, she could get familiar with how it is to insert her own finger, or if she's okay, the husband can insert starting from one finger after wearing gloves. Make her comfortable, make them confident that it is not going to cause pain, and they can do this in their own bedrooms. So manual dilatation with one finger. They also they feel with good bonding with each other. If the husband uses a finger, they're more confident about it, and then gradually go to the two fingers with good lubrication. And this can be done over a period of 1 or 2 months. Then Botox treatment is very good in these cases. We can use 80 units to 120 units injected in the pelvic floor muscles, which are really very, very taut. Or you can have these vaginal dilators, which you have the special vaginal dilators. But mind you, this is not a treatment which can be done over just one sitting. They will need repeated sittings, repeated counseling, and repeated times there where you make them confident about that it is not going to cause pain. So, of course, if there is it's not going to get accomplished, then you please send her to a sex counselor, psychologist. Okay, then because of this, there can be non-consummation of marriage, and of course, then they will not get pregnant. So where does the problem lie? It could be, as I told you, it lies in the female, and then because there's so much of persistence and so much of issues because of vaginismus that later on the male also gets erectile problems, and then when the female becomes okay, it then gives rise to erectile dysfunction in the male partner. What are the issues? They could be ignorant about sexuality. They may have an experience of coitus with another mate. Googling, being all the time on the phone, this is a big way in which it comes in the way of vaginismus and non-consummation of marriage. They may go to alternative medicine. There are thousands of them which are there on the roadside, which will allow a quick fix to all this problem. And there could be a role of religious priests to drive away the evil spirits. And basically, it could be that one partner is anxious, leads to the penetration being painful, there could be bleeding, and then you have the male also coming with the same issue. And hence, it is you have to tackle both the couple simultaneously. So intact hymen, what do we advise? Now, about intact hymen, there's a big issue about a very small tissue. Most often it is important that we remember that there is nothing like an intact hymen by and large in our girls, because they are right from the childhood and right from their teenage. They are active physically, they exercise, they play, and probably there's nothing like an hymen left in them. But lack of anatomical knowledge is also a contributing factor. There could be a knowledge of sexual position they may not be having. This has to be told to them. The foreplay is very important. For her to get aroused and have some sort of lubrication, the foreplay should be really emphasized in both of them. And all these lubric gel, Kim Plus, Arjob gel, there are lots of gels. I have a slide about them, about the vaginal moisturizing agents, which she can use. They are really very helpful. The position, proper position should be told to them. And if it is not corrected, then it gives rise to severe marital distress, frustration, depression, anxiety for the couple. Gradually, it leads to adjustment problems, hostility between the couple, and may even end up in divorce. And these are the male factors which are contributing to non-consummation of marriage, erectile dysfunction, premature ejaculation, lack of sexual desire, homosexual orientation, sexual aversion. Let's not forget about the male factor when we are considering non-consummation of marriage. And these are the vaginismus is the most common cause. Other causes are sexual aversion disorder, sexual desire disorder, and lesbian orientation. And there could be couple problems also. There could be myths associated with intercourse, that man should be the sexual leader, women should not initiate sex, respectable people should not enjoy sex. If sex is not doing something, it's wrong with the relationship. The size matters. Sex with virgin increases sex power. Once homosexual, always homosexual. Suhagrat, there should be blood during the suhagrat. So these are all myths which are associated with the first night and the marital life. So this is probably one has to go deep into the history and find out as to what the problem is. And we have to probably, increase the communication between them, heighten sensory awareness. So that is about non-consummation of the marriage. This is a very big topic, mind you, friends. So it's very difficult to cover all of it. I'm trying to just touch the important points. So vulvodynia or vaginismus is also one issue which can be, which needs to be looked into. So what are the criteria? There are two types. So vulvar vestibular subtype, right? So this is vulvodynia. This is severe pain on vestibular touch or attempted vaginal entry, tenderness to pressure localized within the vulvar vestibule, physical findings confined to the vestibular erythema of various degrees. Pain is provoked and localized, but commonly seen in women aged 50 or less. And the aesthetic vulvodynia subtype, pain is constant and may felt beyond the confines of the vulvar vestibule. It is unprovoked, diagnosed mainly in women who are peri or postmenopausal. Now, endometriosis again is a very important cause of painful periods. We are all very familiar. The most important symptom is chronic pelvic pain, dysmenorrhea, deep dyspareunia, dyschezia, erectile bleeding, and we must go into the details of the history and find out whether it is deep dyspareunia or there is vaginismus, and most often a sonography will or an examination will really come to the conclusion. And rectovaginal endometriosis is the most severe form which can give rise to dyspareunia, and laparoscopy really and medical treatment may also help in some, but surgery definitely improves the symptoms up to 70%, and backup medical treatment may be required. Now, let's not forget the older women. They also want to be sexually happy. Now, this was a study which was found that in about 448 women over 60, 66% were sexually inactive. 12% of married women had difficulty with intercourse, and 14% had experienced dyspareunia. What is the reasons of decline of the sexual issues or increase in the sexual issues? And it is because of the peri and the menopausal hormonal changes, urinary incontinence, altered body image, boredom. They may just not be interested. They may be worried about their grandchildren being unwell or their in-laws being, unwell. So that could also be playing on their mind. Frequency of infections, the dryness in the vagina because of lack of estrogen, lack of hormones, it may be very painful to have intercourse, lack of communication, religious beliefs, taboo topic. It's even a taboo that she would even consider discussing with the doctor. So in the menopausal age group, mind you, that or in the perimenopausal age group, if you ask her, you would probably get the right answer from her, whether she's interested and if she's having any problems in having sexual intercourse. So it was reported that quite a few women had hypoactive sexual disorders in the elderly age group. And what was the reason is because of the decrease in the circulating androgens. So the circulating androgens, which are less in the prepubertal is also less. It is at its peak in the between 20 to 30, gradually keeps declining, and the circulating DHEAS is a reflection of the adrenal secretion of DHEAS, and this, because it decreases, it causes a decrease in the desire to have intercourse. So as you have seen, declining estrogens causes increased tissue fragility, increased vaginal and urinary infections, irritation, dryness, urogenital pain, and susceptibility to vaginal tissue trauma. So declining estrogens impair sexual desire. Indirectly, it induces vulvovaginal atrophy, leading to sexual pain and trauma during intercourse. And also neuroendocrine estrogen depletion adversely affects sexual response by acting through the CNS and expresses mood swings, hot flushes, irritability, memory lapses, and insomnia. So our next speaker is going to really talk on all these issues. So I'm not going to discuss in detail. And this is the couple who's now waiting, is asking, the husband is asking the wife, has your hot flush gone yet? Or can we now close the window? She's feeling so terribly hot. So this is what this is what happens in the reverse menopause: senescence, loss of sex hair, loss of libido, loss of bone density, loss of stature, loss of muscle mass, and immunosenescence. Now, there are lots of medicines which are associated with the female sexual dysfunction. This is a very good chart, and hence it's important that when we are treating, when they are on all these medications, especially the psychotropics, the cardiovascular and the antihypertensive medications, they do decrease the desire. So SSRIs and the tricyclic antidepressants and the monoamine oxidase inhibitors, they affect the sexual desire. And if we increase the dose, because she complains, then her problems will increase. So probably you have to fine tune the dose of all these medications and then take care of her sexual problems. So antidepressants, which I told you over here. Even the glucocorticoids suppress adrenal androgen production, and it can cause oophorectomy. This is also very important, this, because even if you, I would really comment and find out whether everybody wants to do a bilateral oophorectomy with hysterectomy. I do not do it, because even if there's small amount of hormone which is being released by the menopausal ovary or during perimenopause, one should really one should not do a oophorectomy during hysterectomy as a routine to take care of future ovarian malignancy which can occur. And if you have to remove the ovaries in a patient who is 35 or less than 40, 45, please put her on estrogen, because otherwise it can give rise to premature ovarian failure. So these are the 7 menopausal drafts: itchy, bitchy, sweaty, bloaty, sleepy, forgetful. Okay. So the psychosexual counseling, lubricants, moisturizers, topical estrogens, osmifene, testosterone, DHEA, tibolone is what. Estrogen therapy locally is very good. And even the oral medication, if she's taking, and especially if she has a premature menopause, that let's say if she has a menopause at the age of 40 or 41, it is better that she is put on HRT, because otherwise she'll have all these issues of menopause and the sexual issues also. And you can have estrogen patches, gel sprays. Now, testosterone therapy is a very important treatment. One must remember there are a lot of myths and misconceptions associated with testosterone, and that it is the most abundant biological active female hormone. It is essential for physical and mental health in the woman. It is not masculinizing, does not cause hoarseness, increases the scalp hair growth. It is cardioprotective. Parenteral testosterone does not adversely affect the liver or increase clotting factors. It is mood stabilizing, does not increase aggression. It is breast protective. And of course, the safety is under research. And these are the various formulations which are of testosterone available. Testosterone matrix patches, sublingual composites. I'll not go into the detail. These are custom formulated gels. Testosterone implants were available, which have now been withdrawn. Study on sildenafil it showed that probably it did not, there was no difference in the intercourse satisfaction and sexual desire after 3 months of therapy. And women who are on HRT had a better overall score. Giving them DHEAS increases the mean and the free testosterone levels. It improves the sexual desire. And it may be helpful in patients with female sexual issues, disorders, and low testosterone levels. Nutraceutical therapy, it may improve the sexual desire, is what was found in this study. These are the various lubricants which are available in the market. It can be oil-based, silicone-based, water-based. The oil-based are thicker consistency, often less irritating. It destroys the latex. So water-based, we'll go into this. Water is a main ingredient. It's soothing and great for sensitive skin, easy to clean off your body and sheets, compatible with all sex toys, but not great for shower or bath because they get washed off, not very long lasting. Silicone-based, unique, silky feel, usually hypoallergenic, super slippery and lasts much longer. So you don't have to reapply as often. Works for water play, can be used with condoms. So these are the few examples: Astroglide, Stick and Glide. And the oil-based, it feel great. You can find them in your own kitchen. Coconut and olive oil also work extremely well, but not safe to be used with condoms. Good for masturbation and massage. Tibolone, probably it did help for female sexual function index, did help when this study was conducted. So when I asked for a smoky, hot body, menopause was not quite what I had in mind. So these are the various issues what a menopausal woman goes through. These are various aesthetic procedures which are now fast growing. The advent of non-surgical methods and energy sources have taken the world by storm and is finding tremendous response and patient acceptance. The demands for aesthetic vaginal surgery and procedures are really growing by leaps and bounds, as both men and women have become aware of their genital appearance. And they're, of course, definitely good, especially if you're talking for sexual, stress urinary incontinence. Vaginal relaxation or vulvovaginal laxity, which is associated with vaginal delivery, natural aging, and atrophy. And these are the various coverages it had in the press. So to conclude, I'll just have two more slides. The female sexual disorders affects women of all age groups. The impact may be subtle, unrelated emotional disturbance, minor short-term problem, or could also have debilitating consequences. And hence, you give little time during your history taking and you will know whether she is really happy or she needs some attention. These are the various classification. So which classification she goes into, you'll quickly come to know by taking her history and finding out. And there is it goes into each other, the problems. And vaginismus is involuntary and uncontrolled contraction of the vaginal musculature, important cause of non-consummation of marriage, easily treatable by gynecologists. By and large, 90% of them, you do not have to refer them to the expert in sexual medicine. But if you think that there is a deep psychological issue, it's important that you refer them. But by and large, vaginismus can be corrected. It can be very easily managed either by use of vaginal dilators, using finger, or by injecting Botox. Endometriosis, again, a very important cause of deep dyspareunia and may need a rectovaginal nodule, may need surgical treatment. Infertility, as we said, the relationship between infertility and sexual issues every gynecologist should be aware. Taking sexual history, again I repeat, before, during, after treatment is essential. It can be successfully treated in 2/3 of the cases. Educating the couple on the impact of treatment of the sexual function, asking them to seek help if symptoms develop. Thank you for a patient hearing.
Thank you, Sudha. I think the topic which we gave to you, sexual dysfunction in females, is such a vast topic that it is not possible to cover it in half an hour. Before we go to the last speaker, Girish, there is one question which came when Sudha was giving her talk. Dr. Usha Kannai from RR district, she is asking that is it easy for young girls to use menstrual cups? And introducing cups without damaging hymen. Parents are worried. So how to go about it?
Yeah, very nice question and very, important question. Actually, we shouldn't like compel the virgin or unmarried girls to use the menstrual cup. We can just give them the cafeteria approach. We can explain them how to use, when to use, and the pros and cons of the using menstrual cup. If that girl is sexually active, then probably it is easy for her to use the menstrual cup. And sometimes even some girls, they are not sexually active, but they are having the ruptured hymen, and that's why they can use it if they are, they are preparing mentally themselves to use the menstrual cup. But if the girl is having the complete intact hymen, then it is probably, in my opinion, it is very difficult, or probably it is near impossible to use the menstrual cup without injuring the hymen. And I think we should give the complete information to the girl that if any virgin girl she is using the menstrual cup, then it can injure the hymen. And if you are not providing this idea to that girl, then probably it is not good.
There is one comment by Dr. Chitra Bansal from Ranikhet. Their counseling in schools will be very effective.
Yes,
we're just talking before the webinar that we should do some social programs and activities where we can talk about menstrual hygiene, different ways to take care of the hygiene, etc. Now, I think Sudha and Priya, both of you will answer this question after Priya finishes her talk. Dr. Rita Malik from Delhi is saying that with premature ovarian failure, sexual dysfunctions are more profound as compared with other postmenopausal symptoms. So what do we do about it? And she is also asking that, she's from Delhi, that any role of oral DHEAs. So I think, Priya, we can come to your presentation first, and then we can go back to the postmenopausal women and estrogen failure and sexual dysfunction. So now let me introduce Dr. Priya Vora, who is Joint Secretary of Mumbai Menopause Society. She has been member of Managing Council of Mumbai Obstetric and Gynec Society since last 6 years. She is Youth Council mentor of MOGS since 2 years. Also a member of Youth Wing of MWI. She is recipient of MOGS Dr. Durusha Best Committee Award for 2 turns. She has been instrumental in organizing various conferences, outreach programs, and PG teaching activities. And she will be talking today on genitourinary syndrome of menopause, newer therapies. Dr. Priya, then after your talk, you and Sudha can again go back for the question answer session.
Okay, ma'am. At the outset, I would like to thank Ashwini madam and the Integra's medical team for giving us this opportunity. I would be speaking on the genitourinary syndrome of menopause. In 2014, the North American Menopause Society and the International Society for the Study of Women's Sexual Health aptly coined the term genitourinary syndrome of menopause to describe the vulvovaginal atrophy, senile vaginitis, or recurrent urinary tract infections of menopause. As we know that around 50% of postmenopausal women may be affected by the genitourinary syndrome, but many of them do not even report this symptom because they are simply embarrassed. They are unaware that these symptoms are related to menopause, or they believe that their symptoms are just an inevitable part of aging. And therefore, as clinicians, it is very important for us to elicit the history carefully, and we really need to probe into these symptoms, whether they are actually suffering from these or no. Therefore, it is a combination of sexual symptoms, the genital symptoms, and the urinary symptoms. This syndrome affects about 15% of the premenopausal women, and 40 to 54% of the postmenopausal women suffer from the genitourinary syndrome. And in a recent study, only about 4% were able to attribute the vulvovaginal atrophy to the symptoms of GSM, and about 25% of women with GSM actually go to a practitioner for consultation. We all know that with the onset of menopause, there is a vaginal atrophy, and it is a chronic condition. And there is a decline in the levels of the estrogen hormone, and because of which there is a decrease in the lubrication and a feeling of vaginal dryness. The sexual relations become very difficult and even painful. And the vaginal symptoms of menopause, such as dryness, itching, burning, all make a woman's life uncomfortable. Some of them also can complain of the something coming out per vaginum, or they can present with a organ prolapse. And we all know that with the increase in the age, there is increase in the vaginal dryness. And therefore, with the onset of menopause, we know that the early symptoms which actually start are the vasomotor symptoms, and it is seen in 75% in the Western world, and 30% of our Indian women suffer from the vasomotor symptoms. And now the urogenital symptoms, you can see that in the Indian women, it is almost 74%. And in the West, it is 20%. And it is in the middle phase or the mid phase of menopause. And later we have the sequelae like the cardiovascular disease or the osteoporosis and cancer and Alzheimer's. They all occur in the later phases of menopause. Now, let us see the changes in the vulva and the vagina due to an estrogen deficiency at menopause. The vulva becomes flattened and thin due to the loss of collagen and loss of the adipose tissue. The epithelial glands are attenuated and there is a diminished secretions from the sebaceous glands. The clitoris undergoes atrophic changes and also loses its protective covering and is irritated more readily with any type of contact. The vaginal wall becomes thinner, less elastic, pale, progressively loses its rugae, and there are fewer secretions, and therefore there is a decrease in the lubrication during sexual contact. The vaginal surface becomes friable. There are petechiae, ulcerations, and bleeding after minimal trauma, and even healing adhesions may develop between the touching surfaces. The vaginal epithelium, there is a decrease in the blood flow, and there is a decrease in the ratio of the superficial cells to the parabasal cells. The introitus becomes narrow, shorter, and there's an increase in the vaginal pH where it is increased to above 5. And therefore, a lot of our patients even they may present with urological signs and symptoms. There could be increased frequency, urgency, post-void dribbling, nocturia. They may present with stress or urge incontinence, dysuria, hematuria, and recurrent urinary tract infections. And some of them also present with the sexual symptoms and signs. There could be loss of libido, loss of arousal, lack of lubrication, dyspareunia, dysorgasmia, pelvic pain, bleeding or spotting during the intercourse. And therefore, it's very important for us to take a detailed history and analysis of all the symptoms. We needed to look into the other comorbid conditions also which are associated, a careful gynecological local examination of the urethra, vulva, vagina to see the features of hypoestrogenism. There could be an associated prolapse which also needs to be treated, and infections also may be there, and therefore you need to give an appropriate antibiotic therapy also. And the wet smears can be performed which show the decrease in the amount of the lactobacilli, and there is an increase in the leukocytes. And we should not miss the opportunity to do a pap smear, and urine tests can also be performed as the investigations. And now the lifestyle modifications, these non-pharmacological management options are really important and they go a long way. Healthy diet, exercise of moderate intensity for about 150 minutes per day to limit the alcohol intake, reduce smoking, and the perineal exercises are also beneficial and they help to reduce the decline of the estrogen. So they basically slow down the estrogen decline in the menopausal women. Coming to the local antibiotics, as I already said, if there is a associated infection, then you need to give an antibiotic. The probiotics nowadays, we are using a lot of them either alone or in combination with the antibiotics, and they alter the vaginal flora and help to prevent the recurrent infections. The alkaline mixtures can also be used, but nowadays the douching practices should not be followed and they should be applied topically only. And therefore the local estrogen therapy, it is the mainstay, it is the main treatment option which is there for these urogenital problems, and it is available either in the form of the creams, or there could be the vaginal tablets of estrogen, the rings, or the pessaries, and I'll be dealing with them a little later. Coming to HRT and the estriol molecule. HRT is necessary for avoiding the metabolic disturbances resulting from the hypoestrogenism in the postmenopausal women. The unopposed estrogen administration, they definitely pose a risk of the endometrial cancer and breast cancer. And however, we need to give sometimes long-term HRT to our patients to prevent osteoporosis and the cardiovascular disease in the postmenopausal women. And therefore, the estriol molecule, it is a weak estrogen, and it is considered to be more safe than the estrone or the estradiol because its stimulating action on the endometrial growth is far less than the other two, and it also causes less chances of the vaginal bleeding, and therefore it is highly safe. Coming to even estriol, it has a very rapid onset of action and it binds rapidly to the receptors in the target cells, and therefore the estrogenic response it elicits is quite fast. However, the permanence of the estriol in the nucleus of the endometrial cells is shorter. It is only about 9 hours, and in comparison to the other estradiol preparations where the permanence is much longer, it's around 24 hours, and therefore the risk of endometrial stimulation is far high with the other molecules. Now, estriol was also compared with 17 beta estradiol preparations, and it was shown that it had similar affinity towards the vaginal receptors, but very marginal affinity towards the receptors in the myometrium. Estriol, therefore, it is a shorter acting estrogen. It has a rapid dissociation from the estrogen receptors. It is a weaker estrogen and it produces full estrogenic response in the vaginal epithelium. When estriol is given for urogenital atrophy, it helps to normalize the urogenital epithelium. It causes proliferation, differentiation, and maturation of the vaginal epithelial cells. It increases the production of the glycogen, and it helps to maintain a low vaginal pH, and that helps to protect from the pathogens. Usually, the oral preparations of estriol we rarely use unless a patient has other, only for genitourinary, we only use local therapy. That is usually recommended. But if she has hot flashes or vasomotor symptoms, sometimes we need to even add the oral therapy. And therefore, the systemic estriol therapy can also have the following advantages: that it prevents the bone loss and increases the bone mineral density. It increases the serum HDL. It lowers the LDL levels. It improves the endothelial cell function. And it also is atheroprotective. Now, this was the clinical practice guidelines on menopause of the Indian Menopause Society, where it's clearly stated that vaginal estrogen therapy is the most effective in the treatment of urogenital atrophy. Low-dose vaginal preparations are as effective as the systemic therapy, and some women on oral estrogen may require additionally even the local therapy. For recurrent attacks of atrophic vaginitis, it requires the use of the smallest effective dose over a period of time, and after control of the acute symptoms, the dose of local estrogen can be tapered off for a long-term maintenance therapy. treatment can be continued indefinitely. However, the safety data from various studies, they do not go beyond 1 year. And therefore, we should give our patients maximum around 6 months to 1 year and not beyond that. Recurrent urinary tract infections in this age, after ruling out other causes, may benefit from the local application of the estrogen therapy. And like all HRT, it should be the lowest possible dose for the shortest duration of time. Now, this was the North American Menopause Society position statement of 2013 on the management of symptomatic vulvovaginal atrophy. And it clearly states that low-dose vaginal estrogen is recommended as the first-line treatment option in vulvovaginal atrophy for symptomatic women with moderate to severe VVA and those with milder VVA who do not respond to lubricants and moisturizers. Low-dose vaginal or systemic estrogen remains the therapeutic standard. Low-dose vaginal estrogen is preferred when vulvovaginal atrophy is the only menopausal symptom. Vaginal estrogen may be continued as long as bothersome symptoms are present. Now, when the creams were given, these were the studies which were there, where weekly the response on the creams was assessed, and at the end of the 6 weeks, it was found that the lactobacilli appeared in 61% of the patients, the gram-negative bacteria decreased in 31%, the pH reduced from 5.5 to 3.7, and we also have the vaginal tablets which are marketed as Vagifem, and they are about 10 to 25 microgram, but we do not have it in India as yet. And the 17 beta estradiol rings, which can also be used for the local therapy, which right now are not currently available in India. And therefore, in the Indian market, we have the two main creams, which is the estriol cream and the conjugated estrogen vaginal creams. These are the most two important. The estriol cream has 1 milligram per gram and 0.5 milligram contributes, it is equal to 1 standard mark on the applicator. The conjugated estrogen cream has 0.625 milligram per gram and 1 standard mark on the applicator corresponds to 0.625 milligram. And when you want to give a low dose, we need to give till 0.5 mark on the applicator, which is equivalent to 0.3 milligram. And it is very important for us to know this because we need to tell our patients to what mark they need to take, especially when we need to give them a low dose. And the main advantages of these vaginal preparations and these creams are that they avoid the enterohepatic circulation. And with the low dose or the standard dose preparations, there is no endometrial stimulation, and therefore the surveillance of the endometrial thickness is not really required. And you do not even need to supplement with the progesterone because with the local therapies, there is hardly any systemic absorption. There are no systemic side effects, and it has only local side effects, minimal effects may be there. Coming to phytoestrogen, we have soy isoflavone 7 gram tubes which are available, and these can be specially beneficial for the patients in whom estrogen therapy is contraindicated, and 1 tube that is 7 grams need to be given twice a week, at least initially, and then you can reduce the dosage further for maintenance therapy. Now, therefore, the prescription for menopausal women with urogenital symptoms would be either 0.5 milligram of the estriol cream or the conjugated estrogen. When you want to give the standard dose, it's 0.625 milligram. And if it's a low dose, it's about 0.3 milligram. It initially has to be given daily for 2 weeks, followed by bi-weekly applications for 6 to 12 weeks at bedtime, and may be continued for 6 months to 1 year. And there should be a gap of at least 12 hours between the application and the sexual contact. There was a Cochrane database on 2016 where local estrogen, the different options like the rings, the pessaries, the tablets, and the creams for vaginal atrophy in postmenopausal women was studied, and it came to a conclusion that there was no difference in the efficacy between all these various preparations. All the preparations were equally effective in relieving the symptoms of vaginal atrophy, and they were significantly better than the placebo and the non-hormonal gels. If there is a sexual dysfunction which is associated, then tibolone in a dosage of 2.5 milligram daily for 6 weeks to 3 months can be given, and these patients can also be given the estriol cream, that is 0.5 milligram, or the conjugated estrogen cream, or the tablet estriol 1 milligram or 2 milligram if urogenital atrophy is also present. Coming to the lubricants, these are the non-physiological usually, and we have oil-based and they are water-based. Oil-based are inferior to the water-based lubricants, and they are, however, sometimes non-physiological. They give only a temporary relief of symptoms and can have a vaginal irritation. And we have even the moisturizers. They lead to a reduction in the vaginal pH. However, the effect on the maturation index is not really significant, and therefore vaginal estrogen therapy remains the treatment of choice. And nowadays we even have the intravaginal dihydroepiandrosterone, where there are phase 3 trials are yet on. It's a randomized double-blind placebo-controlled trials have been done with intravaginal DHEA, and they found that there was an increase in the superficial cells percentage, there was a decrease in the parabasal cells in the vaginal epithelium, decrease in the vaginal pH, and decreased sexual pain. And when the patients who used DHEA application, when it was compared with the placebo, they found that the vaginal secretions improved, the epithelial thickness improved, and the color of the vaginal epithelium also improved with the DHEA therapy. But as a promising novel therapy, however, we need more research is required to assess the long-term efficacy and the safety of DHEA. Coming to ospemifene, which is a selective estrogen receptor modulator, and it is FDA approved, and it is used for the postmenopausal dyspareunia in a dose of 60 milligram daily can also be given. And now is the era of vaginal rejuvenation. We have the two main type of lasers which are there, the microablative lasers, which have the carbon dioxide lasers, that is the fractional microablative CO2 lasers are there, which promote the regeneration of the collagen fibers. They restore the rehydration of the vaginal epithelium and elasticity of the vaginal mucosa. And even the non-ablative erbium Nd:YAG lasers can also be used. The treatments should be started early before the irreversible atrophic changes have already occurred. Treatment needs to be continued to maintain the benefits. All local estrogen preparations are quite effective, and the patient preference will help us to decide. So we need to counsel our patients and ask them what they prefer, and then render them the treatment of choice. Delay in starting the local treatment will reduce the degree of the response. Initial loading dose to stimulate the receptors, followed by a low maintenance therapy bi-weekly can be followed. The take-home points: the genitourinary syndrome of menopause is a common problem. Therefore, we need to counsel our patients to recognize the urogenital symptoms. Unlike hot flashes and night sweats, which resolve over the time, urogenital problems are progressive and definitely require to be treated. Vaginal estrogen is preferred route to the oral therapy, and estriol is the preferred molecule. And now the newer treatment options like DHEA and the lasers can also be offered to our patients. Thank you for a patient hearing.
Dr. Priya, you have enumerated the different modalities of treatment for genitourinary syndrome of menopause. The previous question was about oral DHEAs. You said about vaginal DHEAs. So anybody can answer, Priya, Sudha, that are you aware of oral DHEAs use for the same problem?
If you use DHEAs, definitely the levels of the it may improve, but it is not definite that it will be the androgen levels in the blood may improve, but whether it will be really effective in all cases is I have not come across any great study to really come to any conclusive evidence for that. And for how long would she take? And it also depends on what symptoms she has. Now, if she has just vaginal dryness, if that is her symptom, then probably the local estrogen treatment, the cream, it also depends on which age group she is. Suppose she's a case of premature ovarian failure,
Yes,
then
that
probably
was the
the
question,
hormone replacement would be more indicated and more beneficial. But if you have a 55 or a 60-year-old woman comes with dryness, genitourinary problems, then probably the local estradiol cream, conjugated estrogen, which is available, would be more beneficial. So it would then depend on what the case is.
You are right, Sudha, that it depends on what are the problems.
Yes.
So that we can cover as a whole umbrella and not only one problem. And that is, and in fact, even in spite of giving oral, even estrogen therapy, vaginal estrogen may be still more useful.
Yes.
So we had to combine oral as well as the vaginal therapy sometimes.
Yeah.
So now, Dr. Priya.
And one more point, can I just add?
Yeah.
Quite a few women come with repeated urinary tract infections.
Yes.
And the local cream you give them, and you give them, 1 tube or 2 tubes they can use, and it really works very well. The chronicity of the urinary tract infection gets corrected with that. So I think that is a very important indication, for women.
There is a question by Dr. Vikas Gangurde, who is from Kotamgaon, district Nashik. Any role of rejuvenation in gynec and old ladies? Because I think, Dr. Priya, you also mentioned about rejuvenation surgeries, and we are going to have a whole lecture on cosmetic surgeries and rejuvenating surgeries in our next webinar. But do you have any personal experience? Have you sent your patients for these rejuvenation surgeries? Anyone can answer, all three of you who have sent your patients for such surgeries. Any opinion? I think maybe
Madam,
the cosmetic.
Priya, you want to take it? Priya, you want to take
I
it?
can. Okay. Madam, I don't have a large data, but I have done with 2 patients and they were quite happy with it. We had used the Thermiva laser, and which is a radio frequency laser. But again, they need to be doing it every 6 months to 1 year. So once you do the first time, then after 1 more month, after 4 to 6 weeks, you have to repeat, and then you need a top-up dose. It's nothing is permanent. So you need to do it again, maybe after 6 months to 1 year, based on her symptoms. And again, for a prolapse, so only mild prolapses or a mild SUI, or if it's a lot of dyspareunia or dryness, because they help to increase the lubrication of the vagina, and there's a remodeling of the collagen. So if they feel very loose or lax, then, and if they are multiparous, like if they've had a number of vaginal births, then in these patients it may be definitely beneficial.
So every therapy which is a newer therapy, there is some role. Maybe it is a specific role or restrictive role, but we have to identify that which are the women who will be benefited by these newer therapies. There is question from Dr. Lakshmi Kumari Perla from Pallakollu. What is the name of estrogen patch? Because patches are not available now in India. So they are asking whether any experience of estrogen patches. They were available in between, but again they went out of fashion and they were not used because of a lot of sweating which occurs in Indian women, and that's why they just come off and they are not very useful. And that's why at present we have maybe local skin penetrating cream and gel, but we do not have any estrogen patch available in India. Dr. Mini Sanganeria from Navi Mumbai, she wants to ask, vulvovaginal dynia in postmenopausal women, all measures whatever are described have been carried out, but there is no relief. So any suggestion? Vulvovaginal dynia in postmenopausal women. I think we can again ask for a gabapentin. That is also very useful. And sometimes even Botox injections can be tried. Or this rejuvenation therapy, which we were describing just now. That also is one of the options if all other measures have failed. And definitely, maybe you can refer her to a person who is, expert in managing Botox injection, etc. And there is one more question. Again, Dr. Rita Malik from Delhi is asking, is vaginal DHEA available easily? Because we have talked about it, she is asking about the availability. Is it easily available in India?
I'm not aware.
No, not yet.
I don't think it's available.
In the pipeline, maybe we will get it. Maybe.
Yeah.
At present, we don't have. But not there. In the grey area, some chemists, they do have some supply from abroad. And maybe if possible, you can get it. But frankly speaking, in India, it is not yet available. Dr. Poonam Agarwal from New Delhi, she wants to ask, what is the role of transdermal estrogens? We were just talking that the transdermal and skin lotion, etc. of estrogen is available. So how it is superior and what is the role in which women? That you can describe. Anybody can take it. Sudha, Priya or Girish?
The transdermal estrogen, this patches or creams? What is the question?
No, cream. Transdermal estrogen cream.
Yeah.
Or even patches. Though they are not available, we can just discuss that what is the advantage of the oral or vaginal.
See, they will still, the transdermal will also go through the hepatic bypass, so it will still be systemic. It will not be local as compared to the vaginal cream is absolutely local. So that is a big difference. And if estrogens are contraindicated in a woman who has got other comorbidities like hypertension and diabetes, and she's had a cardiovascular problem, then probably giving it vaginally would be more safer than giving it on the skin is what I feel. And as I told, in the younger patient, then probably oral is available, which works very well.
So it depends on her so many comorbidities, her age, what is the problem, and then we can choose whether oral is better for her or a transdermal approach is better.
Yeah.
So Dr. Sudesh Purang from Delhi wants to know, a patient had premature ovarian failure at 32 years of age, and now she is 47 years of age, and now she has come to me. So should I start her on HRT now, or MHT, menopausal hormone therapy now? Or is it too late? Is it too late? She is at present 47 years old.
According to me, it's never late. But at the same time, if she has other comorbidities, she has to be told little increase the chance of CA breast and do a sonography and see what is the lining of the uterus. So if there are no contraindications for giving estrogen, and if she's aware of all the problems, she comes for regular follow-up. She understands what the HRT is, and and she still wants it. Then I would leave it on her whether she would want it. There are definite benefits. But if she's obese, she's hypertensive, and she's not used it for so many years, then probably it would. She also may not want to take the risk. So it is, we have to look at the entire picture and not just the age. But all said and done, if there is any patient who comes at 32, 35, 40, 42 with a premature ovarian failure, please start them on HRT. That is really, really beneficial. Give them at least for 5 years. It's quite a safe. That's what I personally believe. And you do their test, you do their mammography, you do their sonographies, and see that they don't cause the little increase in the endometrial problems or the breast issues.
You are very right that we cannot deny them this opportunity. Yeah. They have come to us maybe late, yes, but it is at least definitely she will have some advantages if there are no contraindications. Yes. That is very true.
Yeah.
So, Dr. Girish, there is one question for you from Dr. Divya Salem. Is using menstrual cup can lead to toxic shock syndrome? Because you talked
No. The chances of toxic shock syndrome are very less in menstrual cup because it is made up of the medicated silicone material, which is, I mean, see, using the tampons or the cotton or rayon material, which is very easy to, I mean, that is very easy to harbor for these material to harbor the organisms and pathogens, and that's why the chances of getting toxic shock syndrome in menstrual cup, they are very less just because of that material in comparison to the tampons or the pads.
So that worry is also not there. So
No, not at all.
happy that your talk has created interest in menstrual cups and different ways that we can counsel them and give them advice.
Madam, my first request to every audience is to use the menstrual cup first on yourself in your home, and then you should ask or you should request or you should educate your patients. Because I have talked with so many gynecologists, and unfortunately, most of the gynecologists, they are not using menstrual cup themselves and in their home also. So please, my request to all of you, you start using it, then you will come to know how good it is or how better it is than the other rest of the methods, and then you will definitely get motivation to motivate your patients and your nearer and dearest.
So there are so many newer things and therapies available for the new generation, I would say, and even old generation. And
Exactly.
I want to thank all three of you for your wonderful talks and replying to the questions asked by our delegates. And I would like to again thank Integres for giving us opportunity to conduct this webinar. And I'll be very happy to announce that on 19th March, on Friday only, we are going to have the second webinar in the series. And the topics will be perineal wash and vaginal probiotics for better vulvovaginal hygiene. The second talk will be on pre-malignant lesions of vulva. And the third talk will be cosmetic procedures for vulvovaginal problems, where today we have already discussed little bit of it and what are the indications, contraindications, etc. So my request to all the delegates, please join in and please inform your friends also to attend our webinar. Now over to you, Dr. Poonam.
I would like to thank you, ma'am, Dr. Ashwini ma'am, and all our speakers, Dr. Girish sir, Dr. Sudha ma'am, Dr. Priya ma'am. Indeed, their sessions were very informative, very enlightening, and I hope all our viewers have benefited from our session. And looking forward for more such educative sessions.
Poonam,
Yes, sir.
do you have 5 minutes with us?
Yes, sir.
So we should end up this session with one of my song, if
Oh,
Definitely.
it will be wonderful.
so. May I request everyone to use the headphones, please, if possible, very easily.
You're going to sing live, Girish?
No, madam.
Okay.
One recorded song.
All right.
It was recorded for one of the programs of our Foxy.
All right.
Yeah.
Girish is a singer and he was awarded by Foxy as the best singer.
Yeah. Thank you, Dr. Ashwini. It was very well conducted. Thank you very much. Let me take
Sudha madam, is it audible? Video?
No.
Oh, no.
Just a moment.
Sir, first play the video and then share the screen.
Just by the time Girish is organizing for his video.
Dr. Ashwath sir,
Is it audible now?
Vice President Foxy, and Secretary General Dr. Jaydeep Tank for this.
Audible, sir, but we cannot see them.
And
Shimon, is it audible now?
Sir, it is audible, but we cannot see the video. I would suggest you to stop sharing the screen, then play the video and pause it and then share the screen. The player has to be on, sir, before you share the screen.
Okay.
So Poonam, can I just share that our third webinar in the series will be in April, And the first talk will be on the role of laser surgery in vulvovaginal ailments. And there will be panel discussion on dealing with vulvovaginal problems from menarche to menopause.
Also, special thanks to all the coordinators of this program. Dr. Priyanko, Dr. Shashwat, and everyone. And special thanks to Swaizera people, Mr. Suboji, Smita, Mrinali, and very special thanks to the judges of both the categories, singing and dancing. Thank you very much. And I hope that you will like this performance. कहीं तो मिलेगी मोहब्बत की मंजिल ये दिल का मुसाफिर चला जा रहा है कहीं तो मिलेगी मोहब्बत की मंजिल ये दिल का मुसाफिर चला जा रहा है नज़र में सजी है ख्यालों की महफिल उम्मीदों का सूरज ढला जा रहा है जिंदगी की शम्मा खो जाए दिन क्या पता कब कहाँ चल के बुझे जिंदगी की शम्मा खो जाए तुम क्या पता कब कहाँ ये कैसी बदल है ये कैसा सफर न किसी को पता न किसी को खबर है तूफान में कश्ती बड़ी दूर साहिल दिल का मुसाफिर चला जा रहा है I wish a very best luck to all the participants in both the categories, dancing and singing, and I hope the best will definitely कोई सितम कोई सजा दिल भूल नहीं कभी मुसाफिर चला जा रहा है, कहीं तो मिलेगी मोहब्बत की मंजिल, दिल का मुसाफिर चला जा रहा है। And very special thanks to the team members and the all viewers, all the PG students, all the people from PG Forum who joined this program. Thank you very much. Thanks.
Very nice.
I hope we ended the program with banquet.
Yes.
Yes.
Thank you, madam. Thank you so
Definitely,
much.
definitely, Dr. Girish sir. I must say your voice is mesmerizing,
Yes.
melodious, and it was indeed
Thank you.
a relaxing start to the weekend. Thank you, sir.
Thanks a lot.
Thank you, everybody.
Thank you, everyone.
Thank you,
Thank you,
everyone.
madam.
Thanks.
Thanks.
Thank you, doctors.
Thank you. Can we
Thank you.
leave now?
Thank you, everyone.
Thank you.
Bye, Priya madam.
Bye,
Your lecture
bye,
was
ma'am.
fine.
Bye,
Superb.
Dr. Ashwini.
Bye.
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 Bye, Priya.
Bye, Dr. Tandon.
Bye.